Now I invite Dr. Tinku Bali. She'll be talking about nucleus management in presence of PCR.
Hello, good morning everyone. It's my pleasure and privilege to be here this morning. And I'll be talking on the nucleus management in the presence of a posterior capsular rupture, and I'll be giving you more of a vitreoretina perspective since I'm a vitreoretina surgeon. Well, posterior capsular rupture is an unfortunate complication of cataract surgery and can have dire consequences. But if managed properly, the risk of complications can be minimized and the results can be as good as if it had never happened. The first thing is to anticipate a posterior capsular rupture in these type of cases: posterior polars, hard cataracts, post-traumatic cataracts, and you should be having a surgical strategy in your mind even before you start the case. Your staff should be briefed, your instrumentation should be ready, your vitrectomy machine, your cutter should be all in place so that you're not faced with a surprise when it happens. Recognition we all are familiar with: a sudden deepening of the anterior chamber, non-rotation of the nucleus, loss of followability, tilting, and a bright glow. So the first thing is not to panic. Do not get overwhelmed with the situation. Instead, organize yourself and face the situation fair and square. Now, the management strategy would depend on the extent of the PCT, the intactness of the hyaloid face, the location of the nucleus, whether it's in the posterior chamber or in the anterior chamber, the availability of the equipment, the availability of IOLs, knowledge about a proper anterior vitrectomy, and the availability of a VR surgeon. When faced with a threat, we stop but do not retreat, and the same applies here. Do not panic and suddenly withdraw the phacoprobe, because hypotony is the number one enemy when this happens. So a PC tear does not equal an anterior hyaloid face rupture, and when you withdraw your phacoprobe image, suddenly the anterior hyaloid ruptures and vitreous comes into the anterior chamber, as you see here in these pictures. So what you do is you stop. You see here PCT occurring. So whenever you see a PCT occurring, you stop. From the side port, you inject viscoelastic. A dispersive viscoelastic is preferable. When you have a stable chamber, a very well inflated anterior chamber, that is the time you gradually withdraw your phacoprobe. So you see here, no more vitreous comes in front. After that, the other important thing that you should know about is how to do a thorough anterior vitrectomy. Well, when you do a vitrectomy, it should always be in a closed system, so always it's better if you can suture the main wound. A bimanual anterior vitrectomy should be done. Always remove the vitreous before you start tackling the lens fragments. Use a high cut rate, the highest cut rate that your machine supports, and a low vacuum. And in case you're using the machine that is built into your phaco machine, the vitrectomy system built into the phaco machine, then use the cut IA mode. So as you see here, the surgeon is using this main port to do a vitrectomy. You see how unstable the chamber it is. The more unstable your chamber is, the more vitreous keeps prolapsing forward. So this is not the way to do an anterior vitrectomy. Instead, make a side port. Suture the main wound if possible, otherwise hydrate it, and then you see how stable the chamber is now when you're doing your anterior vitrectomy. When you do an anterior vitrectomy, the face of the probe should be facing forward. You should be keeping away from the margins of the anterior capsule so that you do not damage it inadvertently. Now, maneuvers like this, like using Weck cells or using the scissor and pulling the vitreous and cutting, should not be done. You have to respect the vitreous base to prevent tears. So you see this kind of a maneuver where you're pulling and tugging on the vitreous can cause small tears here at the vitreous base, which could cause a retinal detachment subsequently, months or even years down the line. The plas planar approach to do an anterior vitrectomy is preferred by some and is of an advantage because it reduces the vitreoretinal traction and provides a better endpoint. You get better access to the remaining lens material and you're more or less likely to damage the anterior capsule. So it is not very difficult to master this technique. You have to make pars plana incisions. Your vitreoretinal colleague could help you out and teach you how to make these incisions. And this is how you go from the pars plana and do an anterior vitrectomy. Now, the nucleus management would depend on how much of the nucleus is left. So if there's a very small piece, you could even continue your phaco. You could get this nucleus into the anterior chamber, put a high viscosity viscoelastic, and then continue your phaco in the anterior chamber. You could enlarge the incision, convert to an ECC. You could use the chopstick maneuver where you use two instruments to get these nuclear fragments out. And in case there's a nucleus drop, then it's best left to the vitreoretina surgeon. Now, if soft lens matter is present in the anterior chamber, it should be carefully removed with the suction mode of the cutter before doing the anterior vitrectomy. So you can use your cutter itself to do the removal of this soft lens material. You use the suction mode. As you see here, it comes very easily with this cutter. Get it right into the center and then suck it. Now, a drop nucleus, as I mentioned, is a dire complication for the cataract surgeon, but it's a fairly straightforward problem for the vitreoretinal surgeon. So, drop nucleus cases, I always say, referred to a retina surgeon, fall into two categories, well managed and poorly managed by the anterior segment surgeon. So, this is something that has been repeated on and off. Don't chase after the falling nuclear fragment. Avoid unnecessary manipulations, and in order to avoid vitreous traction, retinal detachment or CME. The anterior segment surgeon should do a proper anterior vitrectomy and ensure there is no vitreous in the wound. And if the required instrumentation to do a good vitrectomy is not available, then it should be left for the posterior segment surgeon to do it. Retain a good capsular support. IOL placement should be done only if you feel it is stable, and an AC IOL should be avoided in case there's a nucleus drop. Tricot staining can be done in the anterior chamber to look for residual vitreous. The wound should be closed so that there's a non-leaky chamber for the posterior segment surgeon. Always have an arrangement for referral with a vitreoretinal colleague and establish the protocols for the initial management of the patient. The management of a drop nucleus can be done in the same sitting or it can be deferred. It's okay to operate within the first 2 weeks. So to conclude, do not panic and withdraw the probe when you have a PCT. Inject high molecular weight viscoelastic, reduce the bottle height, manage the nucleus appropriately, do a thorough bimanual anterior vitrectomy, place IOL and do not chase the nuclear fragments. Minimum intervention is the best option when you have a dropped nucleus, and a vitreoretinal consultation can often resolve a dropped nucleus with minimum morbidity and excellent visual outcomes. So PCR, if managed appropriately, can give very good results. Thank you.
I thank all the panelists and thank all of you for being here. And with this, we come to the end of this session. Thank you.